Okay, so we'll start with the last session of radiology class today. So yesterday we saw until about how the X-rays are being captured, right? The initial class we saw about the radiation physics, the biology, and the safety. And the second class we saw about how the X-rays are being captured traditionally as well as in the digital method and how it is being processed to get the image. So now, once you have the image in hand, we need to interpret it, right? And there are techniques for taking the X-rays. First, we'll be dealing about the techniques, and then after that, we'll be learning about the interpretation methods. Okay. So, how to take the X-ray? So, when it comes to your intraoral X-rays, that is your intraoral periapical radiographs, we have two main techniques. Okay. First is your paralleling technique. Second is your bisecting angle technique. So, first with your paralleling technique. So, in the paralleling technique, we either place the film by using your hand, we position it by using your hand or by the use of any kind of paralleling devices. The ultimate goal is to have the X-ray to be parallel to the object, okay, parallel to the long axis of the object, and it will be placed as close as possible to the object, okay. So as you can see in this image, the receptor, which is your X-ray film, is placed as close as possible to the object of interest, that is your tooth, and it is exactly perpendicular to the central ray. Okay, so this is your paralleling technique. This can be achieved by either, like I told you already, by placing with your hand and holding it with your hand, or it can be adjusted with the help of some paralleling devices. The ultimate goal is that the long axis of the X-ray, that is the receptor, should be parallel to the long axis of the object, and it should be exactly perpendicular to the central ray. This is paralleling technique. Okay. So the next picture shows you the positioning devices. We call it as XCP devices and all that. So in this, you'll be placing this receptor, the X-ray film here, and you'll be positioning the aiming cylinder towards this ring. Okay, it'll be so it'll be focused there, and the X-rays will exactly hit on the X-ray film without any kind of distortion, unless and until there is any movement because of the patient during the X-ray projection. The chances of artifacts or faulty radiographs in case of your paralleling technique is very, very minimal. Okay, it helps you to reduce the patient X-ray exposure also. So this is about your paralleling technique. These two are your positioning devices, one for the anterior and one for the posterior. We have similar devices for RCTs also. So this is called as an endoray. So basically, when you do RCTs, you need to take two radiographs, right? One with the root canal instrument to check the length of the canal, and the second one you'll be placing the GP inside, and you'll be checking for the master cone X-ray. So these two, when you place, you cannot simply place the normal positioning device because it is going to either distort your X-ray, your root canal instrument, your filing instrument, or it is going to distort your GP. So in either way, the goal is not achieved. So for that only, you have this endoray where it'll have space for your filing instrument or your GP to rest when you're positioning the X-ray film along with it. So it doesn't cause any kind of distortion or disturbance while taking the X-ray during this canal evaluation and as well as the master cone X-ray. Okay, so this instrument is called as X-ray endoray, which is another paralleling positioning device which is used in case of your endodontic treatments. Next is your bisecting angle technique. So when it comes to your bisecting angle technique, we need to remember a few terms. Okay, first thing is your Skizinski's rule of isometry. So the Skizinski's rule of isometry is very, very simple. It is actually nothing but an equilateral triangle. Okay, so the X-ray film should be placed in such a way that the X-ray film and the central long axis of the tooth forms an equilateral triangle with an imaginary bisector bisecting it into two equal triangles. Okay, so this will be one triangle and this will be another triangle. If an imaginary bisector line is drawn in between the receptor and the central axis of the tooth, it should bisect into two equal triangles. This is Skizinski's rule of isometry. So the central ray will again be almost perpendicular, but it is slightly angulated, right? So the central ray the position of the central ray will vary for different teeth. That is for the anteriors, so the posteriors, for the canines and the premolars, it's going to be different. So for the positioning of the central ray and the X-ray receptor, there are a few guidelines that is already given in case of your bisecting angle technique. So if you see in the initial textbooks, I think until the South Asian first edition, this was the one that we it was a hard and fast rule that we had followed. That is plus 40 degrees for your maxillary. It is going to be in positive angulations, and for your mandible, it is going to be negative angulations. The angulations, if you see, it will be mentioned on the your X-ray beam itself. I mean, it will be mentioned on the extended arm of the X-ray machine. So you will be adjusting the horizontal angulation. Remember, these are the vertical angulations. Okay, these are the vertical angulations. Horizontal angulations means moving from right to left. Vertical is top to bottom. So for your maxilla, it is going to be in positive angulations, and for mandible, it is going to be negative angulation. For the maxillary central incisor and the lateral incisors, it is going to be plus 40 degrees. For your maxillary canines, it will be plus 45 degrees. For the premolars, plus 30. And for the molars, it is plus 20 degrees. For the mandibular incisors, central and lateral, it is going to be minus 15 degrees. For the mandibular canines, it is minus 20. For the mandibular premolars, it is minus 10. And for the mandibular molars, it is minus 5 degrees. This angulation was slightly revised in the new textbook, like I already mentioned. So this is the latest guidelines that was given. But I don't know, in case of your a clinical scenario, it is not going to give you much of a difference. But then when it comes to your exam point of view, I think if at all it is asked in MCQ, we might have to write it accordingly. Okay. This was the revised angulation that was given, I think, in the first South Asian edition or the second South Asian edition textbook, White and Farrow textbook. This was changed. Okay. So the first one is for the incisors. Second is for canines, and the third and the fourth plus 30 degrees. It was the for premolars and molars. Likewise, incisors, canine, premolars, and molars. Okay. So basically, you're trying to alter the vertical angulation here and not the horizontal angulation. Please be clear with that. And yes, the angulation is adjusted based on the gradations that is given on the extended arm of the X-ray tube. Okay. So this is about your bisecting angle technique. You'll have the X-ray film receptor, your tooth, and then you'll be adjusting the central X-ray, central beam of the X-ray by altering the vertical angulation according to the tooth. Okay. Yes. So next is your localized techniques. See, for example, when you have an impacted tooth, you cannot always take a CBCT, right? In your clinic settings or in case of the hospital settings, you cannot simply go and take a CBCT. You can use the two-dimensional X-rays to localize certain objects like an odontome or a sialolith, or in case of your impacted canines or any kind of lesions also. No, if you have to view it three-dimensionally, you can tend to take a two X-rays in different positions to localize where the object is present. For example, if it is present buccally or lingually, if it is present, like if you take an IOPA, you'll be able to say, for example, if you have an impacted canine, okay, if you take an IOPA, you can say where the canine is present, if it is present in the apical position or not. It can be sometimes present on the apex of 1, 2, right? So you can say if it is present in the apex of 1, 2, and you can say that it is either mesial or distally present, but you don't know if it is buccal or lingual with the help of an IOPA alone. So for that, what we can do is we can take two X-rays placed at right angles to each other, which means first is an IOPA. You can take an IOPA and see if it is present mesially or distally. Okay. Then you can take a occlusal radiograph. So with the help of the occlusal radiographs, you will be able to say if it is present buccally or lingually, buccally or palatally, right? So these two X-rays are at right angles to each other. So this is the first technique, that is your Miller's right angled technique. Okay. So basically, first you're taking an IOPA radiograph. See, this green color dot is there. No, this is the impacted tooth or an odontome, for example. So with the help of an IOPA, you're able to localize whether it is present mesially or distally to a one particular tooth. And after that, if you take an occlusal radiograph, you'll be able to locate it if it is present within the jawline or the occlusal line. No, you can if it is present within that, then you can say that it is present lingually or palatally, and if it is present outside, obviously it is present on the buccal aspect. So when you take two X-rays placed at right angle to each other, you will be able to locate where the object is exactly present without the help of a CBCT. This is using two-dimensional X-rays. That is, one is your IOPA and one is your occlusal radiograph. Okay, this is one localized technique, and second one is your Clark's technique or your slob rule. That is very familiar to you, right? So in case of your slob rule, both the X-rays are going to be your IOPA only. The difference comes in the changing the position of your extended arm of your X-ray. Okay, so in case of your Clark's technique, what we actually do is first we will take an IOPA. Okay, in the first IOPA, we'll locate it where the object is present, and then we'll try to move the extended tube. Okay, so when you move the tube, when you shift the tube towards the mesial side, and in the subsequent X-ray, if you see the object also moving mesially, then if it is moving on the same side as the tube, then we call it then we can say that it is present on the lingual side. Same side means lingual side. Okay, the object is present on the lingual aspect. If the tube is moved mesially, but the object is being present distally, that is, it is moving towards the opposite side, means then we can say it is present on the buccal aspect. Okay, it's very, very simple. First, you're going to take one IOPA in the proper position. I have an impacted 1-3, so I'm taking one IOPA, placing it in the proper position, like 45-degree angulation. I'm exposing it. I'm seeing that the impacted canine is present at the apex of 1-2. Okay, so this is my first X-ray. So I need to know whether it is present buccally or lingually. So for the second X-ray, what I will do is I am going to shift the cone slightly mesial, which means I'm going to mesial as in, yeah, this side. Okay, shift the cone slightly mesial. I'm going to project it from the mesial aspect. Okay, I'm going to project it from mesial aspect, and I will take another one IOPA. Same 45-degree angulation only, because canine means it is plus 45. No, so same 45-degree angulation. Vertical angulation will not change, but I'm moving it slightly horizontal. The horizontal angulation is getting different. I'm moving it slightly mesial. I'm taking from the mesial aspect. So in the second IOPA, if I see the canine is still present on the mesial aspect of 1-2, means the canine is present lingually. Or if I'm I'm moving the tube mesially, but I see the canine to be present distal to 1-2, means it means the object is present on the buccal aspect. Okay, so it's very, very simple. Two IOPAs, same vertical angulation, but different horizontal angulations. You're moving it mesially or distally, and you're taking the second X-ray. If it is moving towards the same side, lingual, opposite side, buccal. That is why SLOB. Okay, slob. Same side lingual, opposite side buccal. This is called as the Clark's technique. The first one that I mentioned is called as the right angle technique or your Miller's technique. So right angled because you're taking IOPA and occlusal. Okay, two X-rays right angled to each other. Okay, so that is your Miller's right angled technique. Okay, so this is about your localization techniques, basically to see your impacted teeth or any kind of mesiodens or impacted canines, odontomes, in case of localizing any kind of lith that is present, that is a hyalolith and all that. Okay, so these are localization techniques. Okay. One more thing that we need to know when it comes to your radiographs is your peripheral eggshell effect. See, this peripheral eggshell effect is something like exposing a curved surface. Example, you have an egg and you're exposing it to an X-ray. What happens is on the top surface of the egg, no, as the X-ray beam when it passes, here you can see in this picture. Imagine this circular portion is the egg, okay, where the X-ray that is passing through the top surface is going to come in contact with only one point, or both the points it is going to be the same. But when it is passing through the central part of the egg, it is going to hit at two different positions. Okay, so it will get attenuated at two different angles, and then only it will pass and go and hit on the film. So what happens is it will give an illusion to give it like something like the egg is the outer surface of the egg is going to be thicker, but actually the egg is not thick. Just because the X-ray is hitting at two different points before it goes and hits on the X-ray film, it gives an effect for like it has a thicker layer, but it's not actually thick because it hits at 2 points. It gives that illusion. This is called as peripheral eggshell effect. The reason why we need to know about this is in case of your amyloblastoma or in case of any kind of multilocular lesions, if you see, no, those have your bone expansions, right? So in such cases, what will happen is this peripheral eggshell effect will be reflected there. Although the bony cortex is not thick, it doesn't become thick there. But what actually happens in case of bone expansion, you have the lesion that causes expansion of the cortical bone. So it gives a curved surface, right? The expansion is going to be like this. It's going to be like a curved surface. So the X-ray, the X-ray that is passing on onto the lesion, that is the curved surface, will have a tangential differential effect and it will hit at two different points, giving an illusion that it is a thicker layer. Okay, so this peripheral eggshell effect is important in case of your bone expansion lesions. That is why we'll have an illusion that that the cortex appears to be thicker in shape, thicker in size. Okay, but it's actually not thick. So that is your peripheral eggshell effect. Okay. So next is your bite wing radiograph. Until now, we saw about IOPA, the different techniques, the localization techniques, and one effect that we usually see. Second is your bite wing technique, bite wing X-ray. So in case of a bite wing X-ray, the X-ray film that we use is going to be the same as that of your periapical radiograph. Only thing is the way in which it is being positioned. In the bite wing X-ray, if you see, we need to see both the maxillary and the mandibular teeth in one single X-ray. Not the complete teeth, but there are certain rules for it. Okay, the space between the teeth, no, it should be exactly parallel. Okay, this paper folding, we call it a tab. We try to fold the paper and then we have an extension onto which we'll ask the patient to bite, and we'll be positioning the X-ray film in such a way. So when the patient bites on this and you position the X-ray and you expose it from the opposite side, what happens is we get the maxillary and the mandibular teeth covered in the same X-ray. So this tab is represented here with a white color line between the teeth, right? It should be exactly flat or parallel to the occlusal plane, okay? And not, both the maxillary and the mandibular teeth should be covered in such a way that it should not be like the entire maxillary tooth is seen with the apex and only some part of the mandibular tooth is visible. It should not be like that. Both should be equally visible and the apex should not be covered, because our intention is not to look at the apex. If you have to look at the apex, you have your periapical radiograph. But this one is mostly to check the crestal bone loss, or in case of any periodontal treatments, no, to evaluate if there is bone growth or not. In such cases only, we'll be mostly using your bite wing radiograph. Or in case of interdental bone loss, basically, for that only, we'll mostly see the bite wing radiographs. So the intention is to see both the maxillary and the mandibular teeth in one single X-ray. Okay. So this is about your bite wing. Next comes your occlusal radiograph. So when it comes to occlusal radiograph, the positioning is going to be different for your anterior teeth, your complete cross-sectional, and for your lateral X-ray. I'll give you the angulations and how it is taken. Okay. So first your maxillary. This is called your maxillary cross-sectional occlusal. Okay. So in case of your maxillary cross-sectional occlusal, you can see for the, maxillary anterior. Okay. This is the maxillary anterior projection. So as you can see, the central beam is going to pass through the tip of the nose. Okay. It will be passed here and the angulation is going to be plus 45 degree. So in that, you'll be able to see the maxillary anterior teeth very clearly along with the apex. In case of your globular maxillary cysts or nasopalatine duct cyst and all, no, this X-ray will be very, very useful, because you need to see the teeth also clearly and the cyst, because it's mostly anterior cysts, right? So you have to see the apex of the teeth also clearly and the lesion also clearly. So for these, you will be using the anterior maxillary occlusal projection with the central beam passing through the tip of the nose at an angle of plus 45 degrees. Okay. Next is the cross-sectional maxillary anterior. The angulation is plus 65. It's not minus 65, it is plus 65. And the central beam is going to pass through the bridge of the nose. Look at the difference. Okay. The anterior is going to pass through the tip of the nose and the cross-sectional is going to pass through the bridge of the nose. You can see here, right? This is the cross-sectional maxillary and occlusal projection. It is passing through the bridge of the nose at an angulation of plus 65 degree. So you will be able to see the entire maxillary arch in an occlusal view, but the apex will not be very clear. Okay, so the entire maxillary arch is visible here. Okay, and this is going to be similar to your lateral projection, just that you're going to shift the cone towards the side of interest. For example, you have any kind of unilateral lesions, you want to see that particular region alone, or in case of any bone expansions and all, no, what we'll do is, for example, if the lesion is on the right side, then we'll focus only on the right side, so the left side will be blurred out. So we'll move the cone towards the region of interest at an angle plus 60 degrees, and it is 2 centimeter towards below the lateral canthus of the eye. This is the lateral canthus of the eye, so it is 2 centimeter below the lateral canthus of the eye. That is the place where your central beam will pass through and hit on the X-ray film. Okay, so this is your lateral maxillary projection. Remember, there are 3 projections: Anterior anterior cross sectional maxillary projection is plus 45, cross sectional is plus 65, and the lateral is plus 60 with 2 centimeters below your lateral canthus of the eye. Okay. Similarly, for your mandible, your mandibular anterior projection, it is minus 10 degree through the tip of your chin. You can see here, right? The central beam will pass through the tip of your chin. Okay. And your mandibular cross sectional, for this, the angulation is going to be 0 degree, which means the central ray is exactly perpendicular to the long axis of the film. Okay, you can see how the film is being positioned here, right? So the central ray will be exactly perpendicular, so it is 0 degree positioning. Okay, it will be parallel. These two will be parallel to each other, and the central ray will be exactly perpendicular to the film. So it is placed at 0 degree. Passing through, the central ray will pass through the midline, through the floor of the mouth, 3 centimeter below the chin. Okay, 3 centimeters below the chin, and it will pass through the floor of the mouth. So similar to your cross sectional, you have your your occlusal radiograph, mandibular lateral occlusal. So in the mandibular lateral occlusal, again the angulation is not going to change. It is going to be 0 degree only, just that it will be positioned 3 centimeters posterior to the chin and 3 centimeters lateral to the midline towards the side of interest. If you want the left side, then you'll be placing the tube on the left side. Right side means on the right side. Okay. So 3 centimeters posterior to the chin and 3 centimeters lateral to the midline. This is the position for your mandibular lateral occlusal radiograph. Okay, mandibular anterior, mandibular cross sectional, mandibular lateral occlusal. So this is your occlusal, 3 types of occlusal projections for your maxilla and your mandible. Remember the angulations alone, and you should know when you have to use which type of projection. Okay, so when it comes to your 2D extraoral radiographs, we have your OPGs, your cephalogram, your skull radiographs, and your 2D ultrasound. Ultrasound is one X-ray that exists in both 2D as well as your, excuse me, your ultrasound is an X-ray that exists in both your 2-dimensional as well as 3-dimensional X-ray. Okay, so 2-dimensional as well as 3-dimensional X-ray. So we'll be seeing each one in brief. Okay, I'm not going to go in detail about anything because everything is in your textbook. Just the exam point of view, what all is important, I'm going to highlight on those points. Okay. So first, the reason why we need an extraoral radiograph is when you have to cover a larger area, and a small size film will not be useful to cover the large area, right? For that, we'll be using an extraoral radiograph. And here, both the X-ray source and the image receptor will be placed outside the patient's mouth. Okay, it's not placed inside, but it's placed outside the patient's mouth. So the X-ray unit, if you see, no, it is almost having the same parameters as that of the intraoral X-ray unit. Just the film size is going to be different. The X-ray unit, as in the exposure and all, is going to be almost the same, like 9 milliamperes and 60 to 70 kbp. All those settings will not change mostly unless and until it is different for the X-ray unit as such. Okay, based on the manufacturer's instructions, but otherwise it's almost the same. And sometimes you might have to alter the kvp and the ma for pediatric patients. So for the pediatric patients, if they're very lean or very small patients, no, you cannot expose them to the same radiation exposure as that given for the adult patient. So for them, we might have to reduce the X-ray exposure. So the settings will be, again, it is inbuilt in case of certain systems. It comes with the manufacturer's instructions, or sometimes you might have to reduce it and then only you have to expose. Okay. So the film size, if you take, no, the receptor. Now we spoke about the X-ray unit first. Second thing is your receptor or the X-ray film. The film size for your cephalogram is going to be almost 8 into 10 inches, and for your skull views, it is going to be 5 into 7 inches. And for the right and left marking is very important, especially in case of your OPG also, because we have to identify the size of the lesion, side of the lesion, and the positioning is very important. No? So the right and left marking is mandatory. In case of the traditional ones where we will be processing the film and all, in that we will be marking the left side. Like I told you the other day, we'll be folding the lead paper and then we'll place it over the cassette and then we'll expose, so that this marking will be seen on the X-ray film after processing. In case of your digital X-rays, it is automatically marked. When you print it, it will be automatically present, which is right and left. Okay. So conventional versus digital is the processing technique. So conventional is where we try to process it using the processing chemicals, same like your conventional IOPS. And digital, obviously everything is going to be digitized. You get the film print on over the printer. Okay. So this is how the initial panoramic radiographs were taken. Just remember two important names when it comes to your OPGs or your external radiographs. First is the person named Dr. Numata, who discovered that we can use an extraoral source of radiation to take an X-ray. Okay, extraoral source of radiation to take an X-ray. This is given by Dr. Numata. And second is Dr. Patiro. So Dr. Patiro is called as the father of panoramic radiography. He tried to modify or bring some advancements to Numata's principles, and then he tried to design the panoramic radiograph. So Dr. Numata and Dr. Patiro, these two people are very, very important when it comes to extraoral radiography. So Patiro is also called as the father of panoramic radiography. Okay. Yeah. So when it comes to your OPG, I want you to remember something called as a focal trough. Okay. So this focal trough is something like the field of, remember the field of interest. Okay. Focal trough. So this focal trough is the area which has to be, which is something like the positioning area. So the teeth has to be positioned properly within the focal trough to get a undistorted image. Okay. So if you don't position the teeth or the jaw within the focal trough properly, it might either be too elongated or too shortened. Okay, so it will not be clear and it will become completely distorted. So this is the three-dimensional curve zone or an image layer in which the structures are reasonably well defined. So beyond this image layer, it can be either elongated or foreshortened or blurred out. Okay, so this focal trough is something like the region, focusing region. Okay. So this X-ray positioning and all, I think practically you'll be taught about it. And one most important thing is we have to get rid of all the metallic objects like any kind of dentures or removable dentures, I mean, okay? The removable dentures, any kind of external jewelry that the patient is having. So anything that can interfere with the X-rays and then create artifacts. So we have to get rid of them before projecting the patient to the X-rays, okay? So this is how an ideal OPG will look. There are certain things that we have to remember when it comes to an OPG. First thing is the structures will be flattened and it will be spread out. It's not like a curved one, but it will be flattened and spread out. Obviously, right? Your mandible, your maxilla, everything are curved areas, but they will be flattened and they will be spread out on a single plane. Something like this. Okay. So second thing is the air spaces. We have multiple pneumatic air spaces, right? Your ethmoid air space, your frontal air space, your mastoid air spaces. Everything is clearly visible in case of your OPG. Soft tissue outlines, your soft tissue border of your nose, the soft tissue border of your ears, and your tragus of the ear. Most of it is visible like an small outline in case of your OPG. Okay. Ghost images, like I already told you, your external jewelry or any kind of metallic objects, they try to create something called as ghost images on the OPG. Apart from that, we also have implants. If the patient is having implants or any kind of radioactive fillings, no, not radioactive, I'm sorry, your radio opaque fillings, no, these tend to sometimes cause distortion and it will give you appearance like ghost images. Mostly your fillings and all will not cause distortions, but it'll be clearly visible on the OPG. Your implants, no, it will not have cause ghost images, but it will be slightly blurred out. It can cast shadows sometimes. Okay, but your external jewelry and all, it will be seen within the area of interest. See, for example, you're looking for some kind of a lesion within the maxillary sinus. You can see, right, how this radio opaque object has been cast a shadow here. So this is interfering with your diagnostic quality, right? So that is why we ask the patient to get rid of all the external jewelry or the metallic objects before taking the OPG X-ray. Okay, so the midline structures will be seen as double. Most common midline structures that are seen as double is your hyoid bone, your nasal septum, you have your vertebrae and all. So it will be seen on either side as double images on either side of the X-ray. Okay, so moving on to the skull radiographs. So we have a few important skull radiographs. I will just brief about each one of it. Okay, so I think this table is given in your white and Faro. For the last minute revision, I would want you to read about this because sometimes they can ask you what is the projection for your water's view or for a reverse town view. So you need to know, and there are for a few X-rays, no, there are small differences in the projections. and they call it techniques. For example, for your PA view, no, we have something called as a Granger projection, Caldwell projection. So the angulations of it and how it is positioned, because some people they might say the tip of the nose alone should touch the X-ray. So another person would say a tip of the nose and the forehead should touch the film. There are modified techniques, so you should be able to answer each one of them in your MCQs, right? So you have to read in detail about the skull radiographs, and for the last minute revision, I want you to revise this entire chart. Please make sure you note down the angulations, and in the positioning, see which one touches. See, for example, in a few, the projection is going to be from behind. In a few X-rays, the projections are going to be from the front. So you have to be familiar with all those things. Okay. So this is about your skull radiographs. So yeah, like I mentioned to you, the first one is your PA projection. Okay, so in case of a PA posterior, a posterior anterior projection. Okay, so it is the X-ray is coming from behind, and you have the X-ray receptor in the front. So the difference in two different projections, the Granger and the Caldwell projection, you can see the angulation is going to be almost the same, and here the central ray is passing exactly through the canthomyatal line. Canthomyatal is your canthus of the eye and the external auditory meatus. So canthomyatal line, and it's exactly perpendicular to the film. But in case of your Caldwell projection, it is 23 degrees to the canthomyatal line, entering from the skull above the external occipital protuberance. And you can see that it is exiting at the glabella. Glabella, you know, right, at the posterior part of your skull. Sorry, glabella is here. Sorry, glabella is in the front, and it is exiting through the glabella. 23 degrees to the canthomyatal line, entering from the skull 3 centimeter above the external occipital protuberance, and it is exiting the glabella. Glabella is the central part in between your eyebrows. Okay. So this is about your PA projections, your Granger projection and Caldwell projection. This is basically okay. The next X-ray is basically to investigate the paranasal sinuses, your coronoid process, and the fracture of the middle third zygomatic complex, your nasoethmoidal complex, and orbital broad fracture. So the projection for that is your, I guess you all would know it, the standard occipitomental projection. So this is also called as the nose chin position. And you can see that the central ray, this is your central ray that is passing exactly through the occipit. That is why it is called as occipitomental. Okay, remember, it is coming from the occipit, passing through the mental region. So occipitomental projection. So the film is placed in front. Okay, film is placed in front, X-ray is projecting from behind. So this is called as, and the patient is positioned in a way in which it is called as nose chin position. Okay, the reason why you're placing it in the nose chin position is the head will be slightly tilted. Okay, so the when the X-ray is being projected, there will be removal of the overlapping bony landmarks. So you will be able to see the region of interest clearly. So basically, I told you that the standard occipitomental projection is for viewing these things. Your investigation of paranasal sinuses, your fracture of coronoid process, and also the interference of the other bony landmarks should not be there. That is why we ask the patient to position in a nose chin position with the radiographic baseline 45 degrees to the central view of the X-ray film. Okay, and the X-ray, the central X-ray will be passing at 0 degrees through the occipit. Okay. So this standard occipitomental projection, there is going to be a variation for it. Okay, so this in the standard occipitomental projection, it the central ray is passing exactly at 0 degrees. In case of your 30-degree occipitomental projection, this is like a modified method. In that you can see the difference, right? The central ray is passing 30 degrees to the line that is passing through the occipit. Here again, the patient is positioned in the same way, nose chin position, but the central ray is directed 30 degree to the horizontal line that is centered through the lower border of the orbit. Okay, here you can see how it is positioned, right? That is the modified occipitomental projection. And there's something called as Bregma-Menton view. See, Bregma-Menton, you have the name itself, right? Bregma is the highest point of the skull, and Menton is here. So it is passing from the Bregma through the Menton, and X-ray film will be placed here. X-ray machine is placed on top. So Bregma-Menton. If it is on the opposite way, then X-ray film will be here, and beam will be passing here. Since it is Bregma-Menton, it has to pass from the Bregma to the Menton. So the X-ray projection will be on top, and the X-ray film will be below. It is passing from the Bregma through the Menton. Okay. Okay, so this X-ray is your paranasal sinus view or the PA view or the waters, your PA waters view. Okay, so basically you can see most of the paranasal sinuses here except for one, that is your sphenoid sinus, your maxillary, frontal, and the ethmoid sinus. Your maxillary sinus is visible here, your frontal sinus and your ethmoid sinuses will be visible except for your sphenoid sinus. To view the sphenoid sinus, we have one more X-ray that clearly shows it, and also you can see this when you can take in an open mouth projection. Okay, so in the PA waters view, only your maxillary, frontal, and ethmoid will be seen clearly. Sphenoid sinus can be seen only in case of an open mouth projection or in a different X-ray, which I will tell you next. Okay, so you can see the positioning of the film and the positioning of the patient here. Okay, this is how the patient will be positioned with the chin touching the X-ray film, and you can see that the central ray is passing from the midpoint of the film, and it is entering from the vertex through the acanthion. Acanthion is your nose part. Okay, so it is passing from the vertex and it exits through the acanthion, and you can see that the patient's head is tilted slightly. So whenever the head is tilted slightly, remember it is to divert or to avoid the obstruction of your hard tissue osseous structures interfering with your image. Okay, so when you tilt your head, these osseous structures will not be covered and the X-ray will go and cover only the air spaces here. So this is ideal for viewing your paranasal sinus. That is why it is also called as waters view or your paranasal sinus view. Okay, so the only sinus that is not visible in the PNS view is sphenoidal air sinus. We should either take it in an open mouth projection or we have to use a submetavertex view. I will be telling you later. Okay. So the next X-ray is important for looking at the fracture of the mandible, lesions such as cysts or tumors in the body or the ramus of the mandible in case of mandibular deformities, hypoplasia, hyperplasia, and in case of maxillofacial deformities, this particular X-ray will be useful. Okay, so that particular view is called as your PA mandible. So this is your ideal PA mandible. PA means what? Postero anterior. So the X-ray has to enter from the posterior region, exit through the anterior region. So for the PA view, you will have the X-ray film in the front and the X-ray source behind it. For an AP view, it is just reversed. AP means it has to come from the anterior to the posterior. No, so for the AP view, X-ray source in the front, film behind it. Okay, so this is PA mandible. So basically it is to view in the posterior third of the mandible, the angle and the ramus. In case of any expansion of the posterior third of the mandibular rami, or in case of any maxillofacial deformities, this X-ray is going to be very useful. And there is a alteration to it that is called as the rotated PA view. In case of the rotated PA view, you can see, right, the head will be slightly rotated towards the region of interest and the X-ray beam is projected centrally. It is exactly perpendicular to the film, aimed towards the side of the face of interest. For example, if you want to look at the right side, means you'll be asking the patient to turn towards the right side and then you'll be then projecting the X-ray. Okay, so this is your actual PA view. You can see that it will be exactly through the center. In case of your rotated PA view, you're asking the patient to slightly shift the head towards the region of interest, and you'll also move the X-ray source towards that particular side and then you'll be exposing it. Okay. This is your rotated PA view. See, this one is actually useful in case of your parotid gland lesions and all. No, unilateral lesions are there, parotid gland lesions and all. If you slightly move the head and then you expose the X-ray, then what will happen? You will be able to avoid the distortion of the osseous structures and you will be able to see the expansion on that particular side, like your parotid gland lesions, or in case of any expansion lesions also, it will be very useful. Okay. So next is your lateral oblique mandible. So lateral oblique mandible also comes in three different directions. Okay. So lateral oblique mandible is like yeah, so lateral oblique mandible comes as a projection that helps to view the anterior body of the mandible. So the projection is actually different here. Okay, so first is the anterior body of the mandible. Second is to view the posterior body of the mandible. So you can see the difference here, right? For the viewing the anterior body of the mandible, look at the X-ray position and how the X-ray source is being projected. Okay, so this is to view the anterior body of the mandible. Next is to view the posterior body of the mandible, and last one is to look at the ramus of the mandible. Okay, so the X-ray film on one side, X-ray source on the other side. This is the region of interest that is going to be covered. Okay, so PA mandible comes in three projections. to look at the anterior body of the mandible, to look at the posterior body of the mandible, and to look at the ramus of the mandible. Okay. So the next X-rays helps you to look at the destructive or the expansive lesions affecting the palate, the pterygoid region, or the base of the skull, to investigate the sphenoid sinus, to assess the thickness of the posterior part of the mandible after any kind of procedures like osteotomy, and also to assess the fracture of the zygomatic arch. Okay, so this particular X-ray is called as the submental vertex. Okay, submental vertex means what? Is passing through the submental region and exiting at the vertex. Okay, so for this, you will ask the patient to bend the head nicely. Um, yeah, you can look at the position here. So you'll ask the patient to bend the head nicely so that the head and the neck will be tipped back and the vertex of the head is touching the cassette. You have the cassette here, patient is lying like this, and the X-ray source is coming from the opposite side. You can see that the central X-ray is exactly perpendicular to the film and it is passing through the mid-sagittal plane between the angle of mandible. So you have two angles of the mandible, right? So it will be passing exactly in between the angle of the mandible in the submental region. This is a submental region, right? So it is passing through the submental region and the X-ray will exit at the vertex. That is why it is called as submento vertex. Okay, and it is going to hit on the film that is placed near the head of the patient. Okay, so submental vertex view, again, it is very, very important to look at the sphenoidal air sinus and the base of the skull fractures. These two are very important indications. And apart from that, there is a modification for your submental vertex view. Okay, this is called as the jug handle view. Okay, the reason why it is called as jug handle view is in case of your fracture of the zygomatic arch, this submental vertex view is very, very useful. Okay, so what you do is we try to reduce the X-ray exposure. Okay, so when you try to reduce the exposure time to almost one third of the normal exposure, what will happen is it will try to opacify or magnify the the cone will be brought as close as possible to the patient so that the magnification of the structures present at the base of the skull will happen, and you'll be able to view the zygomatic arch alone very clearly. You can see in this picture, right? So in case if there is a fracture here, this will be evidently visible. So this jug handle view is exclusively for looking at the fractures of the zygomatic arch. Okay, where the exposure time will be reduced to one third of the normal exposure of your submental vertex view, and the central ray of the X-ray is is brought closer in such a way that the cone will be brought as close as possible to the patient. So because of this, what will happen, there is going to be magnification of the structures at the base of the skull. Okay, and you can be able to view the zygomatic arch very clearly. Okay, so indication of your jug handle view is fracture of zygomatic arch. This reducing the exposure again is useful in case of your submandibular your in case of one kind of occlusal radiograph also. Okay, see, for example, when you're taking your mandibular x-ray for looking at the cylolith, no, we use this technique of reducing the exposure there also. The reason being, your cylolith is not always radio opaque. In the initial stages, no, sometimes what happens is your lith will be it will be similar to a mucosal plug only. Okay, which means it is more mucoid in nature, it is not more calcified. So in such cases, you will not be able to see the lith properly, no, but still the patient will be symptomatic. So in such cases, we should not try to even miss out that small lesion, no. So for that, what we'll do is we'll try to reduce the exposure to almost one third than normal exposure for your occlusal radiograph, and then we'll be taking the mandibular occlusal radiograph to look at the cylolith. So these mucosal plugs will be visible in such cases. Okay, so that is why this technique is also followed there. I just wanted to inform you about this. Okay, so in your submental vertex view, there is a modification that is called as jug handle view, where you reduce the exposure to one third and you place the cone as close as possible to the patient. Okay, so because of that, you'll be able to view the fracture of the zygomatic arch. That is the indication for it. And in case of your occlusal mandibular radiograph, to when you're checking for the cylolith also, you'll be reducing the exposure to almost one third of the normal exposure to view the mucosal plugs. If it is not completely formed as a lith, if it is formed as a mucosal plug, it will be useful for us. Okay. Yes, I want you to take a note of this table. Again, this table is like a keynote for you. Okay. So before you enter the exam hall, I want you to read this completely so that they can ask you in MCQ, whichever thing they want, they will ask you. Like, for example, they might ask you which is the best view for looking at the condyle neck fractures, and they'll give you four options. You should be able to pick which one is correct. Okay. So for looking at the fractures of the zygomatic arch and the base of the skull, the best view is your submental vertex view. For the fracture of the zygoma, maxillary sinus, so fracture of the zygoma, to look at the maxillary sinus and to look at the nasal septum, the best view is your Waters view. Apart from maxillary sinus, also the frontal and the ethmoidal sinus will be visible by the Waters view, and the sphenoid sinus is visible in an open mouth Waters view. Okay. So to look at the condyle neck fractures, the best X-ray is your reverse Townes view. For medially displaced condylar fractures, your posterior anterior view. To look at the coronoid process of the mandible, your best view is going to be your PA skull. For the fracture of ramus and the body of mandible, you have to take a lateral oblique 15-degree mandible. To look at the horizontally favorable and unfavorable fractures of the mandible, the best view is going to be your lateral oblique 30-degree mandible. Okay. So these are the structures that are visible in these particular radiographs. These are the best views to look at those indications. Okay. The one on the right side is the indication, and the second one is your projections. Okay. Yes. So moving on to the TMJ. See, when it comes to your TMJ, you have three main views, okay? Transcranial, transpharyngeal, transorbital. The name itself will give you. Transcranial means it is going to pass through the cranium, that is your head. Transpharyngeal means, okay, so when it comes to your transcranial, there are a few projections for it. Okay, so first is your Lindbaum technique, your Grubcock technique, and your Gillies technique. Okay, so in the Lindbaum technique, if you see, the central ray is passing half inch. Okay, this is inches. Okay, half inch behind and half inch above your external auditory meatus. Your Grubcock technique is 2 inches above your external auditory meatus. This is the central X-ray projection, okay, remember. And then is your Gillies technique. In the Gillies technique, it is half inch in front and half inch above your external auditory meatus, perpendicular to the occlusal plane. So these are the three techniques, okay, Lindbaum technique, Grubcock technique, and Gillies technique. These three are the techniques used for your transcranial TMJ view, okay, transcranial, remember. Next is your transpharyngeal. The other names for your transpharyngeal is infracranial or McQueen-Dell technique. See, I think for one time for our PG exam, no, they had asked about, they just gave the name McQueen-Dell technique, or I think it was Zimmer's projection. They'll just give you the other name, but only if you know that you'll be able to answer that particular question, right? Otherwise, the entire one is going to be wrong. So always remember the other names or the different projections, like we saw there, right? Caldwell technique, Granger projection, and all. So we need to know the other names or the different techniques or the projections that is being given for each of the views. So anything can be asked in MCQ for you. Okay. So the next is transpharyngeal. Like I told you, transpharyngeal means the central ray is going to pass through the pharyngeal region. Okay. So transpharyngeal, and it's also called as infracranial McQueen-Dell technique. Okay. I'll tell you the indications for each, okay? And one more thing I want you to remember is this, for the transcranial technique, it is usually taken in a closed mouth position only, but sometimes it is also taken in an open mouth position, okay? Mostly in a closed mouth, sometimes in an open mouth technique. But this transpharyngeal is mostly taken in an open mouth position only, okay? There's no closed mouth technique, only open mouth position. That also I will give you in a table, okay? So the next thing is your transorbital. So the transorbital is also okay. Under transpharyngeal, there's something called as Parma projection. See, I told you, no, certain modifications will be there. So this Parma projection, if you see, no, basically what they'll do is a lead lined with an open-ended cone will be removed, and the tube head is brought as close as possible to the skin surface. So this basically to magnify the structure so that it reduces the superimposition of the other bony structures. Okay, so whenever they try to remove that open-ended cone is there, no, that extended arm of the X-ray tube, they will remove that and they'll bring the X-ray machine as close as possible to the skin surface. So because of that, what will happen? Magnification of the structures, so that thereby superimposition of the osseous structures will be reduced. This is a modification of your transpharyngeal projection that is called as Parma projection. Remember, the other name for transpharyngeal is infracranial or McQueen-Dell, and the modification is your Parma projection. Okay. The last one is your transorbital, also called as Zimmer projection. So transorbital means what? It has to pass through the eye. So the X-ray, central beam of the X-ray will pass through the orbit of the eye, and then it is going to go and hit on the film. Obviously, whenever it is passing through the eye, no, it can sometimes cause a fear in the patient, right? So because of that itself, this transorbital was not into use in the later ages. Initially, it was used, but in the later ages, they tried to go for the advanced techniques rather than going for something that is going to expose the orbit, because these are sensitive areas, right? So they thought rather than exposing the orbit, let's go for some other modification techniques. So when it comes to the traditional ones, we should remember transcranial, transpharyngeal, transorbital. The other names for it has to be remembered, and how it is passing through the particular region to capture the TMJ. Okay, so I want you to remember this table when it comes to the TMJ views. So first is the transcranial view. It is taken in both the open and the closed mouth position, and it depicts the lateral aspect of the TMJ. Okay, so this helps to identify the osseous changes or surface irregularities of the condyle, coronoid, and all that. And displaced condylar fractures can be captured in this one. And the range of motion of the TMJ also is viewed in case of your transcranial projection. Okay, in case of the transpharyngeal view, it is taken in open mouth position only. It is not taken in a closed mouth position. This helps to look at the medial aspect of the TMJ. Okay, that one was for lateral aspect, this is for the medial aspect of the TMJ. So it helps to capture the fractures of the condyle and the neck region of the condyle, and to look at the erosive changes of the condyle and the coronoid. Okay, and then next is the transorbital. So the transorbital, it gives you the entire mediolateral aspect of the TMJ, and it helps in the diagnosis of anomalies and degenerative changes, and is also an adjunct for looking at the condylar neck fractures. See, ideally for condylar neck fractures and all, your reverse towns only is the common one. These are like adjuncts or supportive x-rays. If at all it's not clear there, or if there's some problem in taking reverse down view, then we go in for this transorbital, transpharyngeal and all. Okay. Okay, so like I already mentioned, the following X-ray is going to is indicated in case of high fractures of the condylar neck, in case of medially displaced condyle, to capture the intracapsular fractures of the TMJ, and to investigate the quality of articular surface in the condylar heads in TMJ disorders, and to look at the condylar hypoplasia or hypertrophy. So in such cases, this reverse Towns projection is very useful. Okay, so in this reverse Towns projection, you can see it is taken in an open mouth position with the patient facing the X-ray, and a patient facing the X-ray, and you have the a patient is facing the X-ray, and the X-ray is being positioned behind. Okay, so the patient is the X-ray film is placed in front. Patient, the forehead is touching the X-ray film, and the X-ray projection is from behind. The only difference between the normal X-ray and this reverse down is it is taken in an open mouth projection. Okay, and the other X-rays are mostly taken in a closed mouth position. Okay, so this reverse down projection, again, this central beam of the X-ray will be projected at an angle. Radiographic baseline is at 30 degrees to the film. You have to remember this one. Okay, open mouth projection, your central X-ray projection, and how the patient is placing their head, and the keeping the mouth open. So these are the things that will help you to differentiate between each of the projection. Okay. Okay. I think this lateral cephalogram is very common one for you, right? So this lateral cephalogram, basically it is used for evaluating the facial growth and development for any developmental anomalies, and also it helps in case of your cephalometric planning is there, no, in case of orthodontic treatment and all cephalometric analysis. For that it is very useful. Okay. So this one other common X-ray apart from OPG, I think Ceph is taken on a common basis. Next is your true lateral skull. True lateral skull. See, true lateral skull is something similar to your Ceph only, but it's like covering the entire skull region. The lateral aspect is going to be visible, and including the entire skull region. Okay. Yep. So indications of your true lateral skull is the fracture of the cranium or the cranial base, the middle third fractures, and investigation of the paranasal sinuses and those affecting the skull vault. Example is your thalassemia and all that hair on end appearance is all there. No, for that you can you can take using the true lateral skull, where you'll be able to see that hair on end appearance here. Okay, it will be visible at the skull vault. Okay. Yes. Okay, moving on to the next X-ray, which is indicated in case of your fractures of the skull vault, investigation of the frontal sinus, and certain diseases I've mentioned, along with intracranial calcifications. So for that, you're going to take a PA skull projection. Okay, PA is see. This PA view is almost same as that of the normal PA X-ray, just that here the entire skull is being covered. Okay, for the normal PA view, the skull will not be covered. No, the vault of the skull will not be covered. For the PA skull, we'll be focusing on the entire thing. So the skull region is also being covered. All right. So I think this is about your skull radiographs and your other extraoral radiographs. One more thing is your Towns view. So reverse Towns view you saw, right? Reverse Towns, you saw that the X-ray film was placed in front and the projection is from behind. Towns view, just remember it's the reverse of the reverse Towns view. Okay. Towns view is the reverse of your reverse Towns view. It is taken in a closed mouth projection. X-ray film is placed behind. X-ray beam is coming from forward. The central ray and everything is almost the same. Okay. Yes, moving on to the next one, that is your ultrasound. See, in case of your ultrasound, it doesn't make use of X-rays, but it makes use of sound waves. The interesting thing about your USG is it has a transducer. Transducer is something like a device that sends the sound signals. It goes and passes through the patient's body and it will get reflected back as echo. Sound will be like it travels in waves, right? So it will travel in waves. It will go and hit on an object and it will be reflected back as echoes. So these echoes will be captured by the same transducer, which is going to be connected to a computer monitor. This will analyze the echoes, it will capture the signals, and it will give you the image. Okay, so this is about your ultrasound, the mechanism behind your ultrasonography. And this ultrasound X-ray can be in two ways, like I told you, 2D and 3D. Okay, 2D and 3D. The difference between 2D and 3D is in the two-dimensional, the image is going to be static. It is just going to give you a static it is like something like a resting position. Okay, for example, if you want to see about the TMJ, okay, so if you take a 2D ultrasound, it will just show how the TMJ is in the resting position. In case of a 3D ultrasound, you will be able to record the kinetics of the TMJ. You can place the transducer and ask the patient to move the jaw. So you'll be able to look at the three-dimensional view and also give you the kinetics of movement, record the kinetics of the movement clearly. Okay, so that's about your three-dimensional ultrasound. Apart from that, we also have something called as Doppler ultrasound. In case of any AV abnormalities and all, no, you have your arterioventricular abnormalities are there, no? In case of AV abnormalities, where you have to look at the flow of blood, whether there is any kind of backflow, or in case of any detect in cardiovascular anomalies and all. For that, you can make use of this Doppler effect, where you can record the how the blood flow is. Okay, which is arterial or if it is venous blood flow, anything for that case, you'll be using this Doppler ultrasound. And yeah, in case of our head and neck lesions, no, in case if we have to see if it is kind of any kind of AV abnormality also, we can see how the blood flow is within the particular lesions. For that also, this Doppler ultrasound is very, very useful. Okay. So these are the different types of transducers, and I think mostly a smaller one, I think the linear or any kind of convex one is used for your intraoral, it is used as an intraoral transducer also. The reason why we take an intraoral transducer is the indication is in case of your submucous fibrosis, no, oral submucous fibrosis, to look at the muscle, anatomy, or in case of any muscle hypertrophy will be present, no. So in such cases also we can make use of this intraoral transducer. And apart from that, in case of any muscle hypertrophy, masseter or anything like that, for that also this USG is kind of useful. Okay, so these are the indications and how the mechanism is taking place. Yep, this is what I was telling you. So the transition from 2D to 3D, it's not easy, but this is how it has happened. Okay. So in case of your 2D, we saw the same matrix with many pixels, right? So pixels is picture elements in case of your 2D. Okay. When it comes to your 3D, we call it as volumetric elements or voxels. See, imagine a wall. Okay. In that wall, you see many bricks arranged, right? So you can see the surface of the bricks, which gives you pixels. Each surface of the brick is your pixel. If you pull out one particular brick, you get one whole cube of it, right? That one particular cube is called as a voxel. Okay, the entire surface has many pixels. If you pull out one particular cube alone, we call it as voxel or volumetric elements. Okay, pixel is picture elements, voxel is volumetric elements. Okay, so this is in case of your 3D. So when it comes to your 3D extraoral, we have your ultrasound again, your CT, CBCT, and your MRI. So 2D versus 3D, like I told you, the range of motion is being captured there. And then moving on to CT. CT is also called as computer tomography. So in case of your CT, what they'll actually do is you have the object or the patient in between, you have the X-ray source on one side and the detector or the X-ray film on the opposite side. So this will move synchronously around the patient, okay, which means synchronously means it will move like these two will move simultaneously around the patient, and it will give you a slice of the image. Okay, it will go in a spiral motion around the patient. Okay, patient will be lying on a table, you will have the X-ray source on top, the X-ray detector on below it, and it will be moving in a spiral direction, like something like cutting. The X-ray will go and cut through the patient and it will give you slices of the image. Okay, so these slices will be arranged like a deck by using the computer, and you'll be able to see the image. Okay, so you can see through each section of the body. Imagine cutting the patient into small slices. Okay, that is how the CT will cut the slices and it will give you as a three-dimensional image. This is about the principle behind your CT. The modification of it is only CBCT, where the shape of the cone is only going to change. I mean, shape of the X-ray beam alone is going to different. Okay. In case of your CT, you have to remember this thing. It is very important. It was named after the person who discovered it. Okay. It is called as CT Hounsfield units. It's nothing but depending upon the X-ray absorption, the each of the entity was assigned a CT number. Okay, that is called as Hounsfield number. Okay, for example, the bone is said to be very dense, right? So it has a higher Hounsfield unit, that is 400 to plus 1000. The air is exactly the opposite. Air is very lighter, right? It's not at all dense. It has nothing, no molecules, so it has minus 1000 Hounsfield units. I want you to remember at least these three. Okay, bone, water, and air, because these have been asked in MCQs before. Okay, they'll ask you what is the CT unit or Hounsfield unit for water. You should not put it as minus 1000. Never get confused between water and air. Okay, air has nothing, so it goes in negative. Water is neutral. Remember, the pH of water is neutral, right? Remember that way. Okay, water is neutral, so it is 0. It is in between. It is in between bone and air. If bone is plus 1000, air is minus 1000, and water is in between with 0. Okay, soft tissues have a Hounsfield unit between plus 40 to plus 80, and fat has a Hounsfield unit between minus 60 to minus 100. Below that only is your lung. Okay, minus 60 is less than minus 1000. I hope you don't get it wrong. Minus 1, minus 2, this is how it goes, right? So minus 1000 means it is very less. Minus 60 is slightly lesser. I know you know the numerical values, right? Yeah, so fat it is minus 60 to minus 100. For lung it is minus 400 to minus 600. For air it is minus 1000. Okay, at least remember bone, water, air. Water is in between, bone plus 1000, air is minus 1000. Okay, this is CT Hounsfield units. CT versus CBCT. In case of your CT, I told you the spiraling action, right? So it has a fan-shaped X-ray beam. In case of your CBCT, the beam is cone-shaped. Okay. The reason why CBCT is I wouldn't say it's useful, but it is like it is superior to your CT because CT has a higher X-ray exposure. It has to spiral multiple times around the patient to give you that slices of image. In case of your CBCT, we will set something called as field of view. Okay, for example, if you just want one particular section, what we'll do is we'll set the field of view to be some 4 into 10 inches, for example. So in such case, what will happen? It will focus only on that region. This cone-shaped beam will go in one particular rotation, same like an OPG. One single rotation, it will give you the entire slice. If you want the whole entire face, then again you'll increase the field of view, and then one single rotation, it will give you the entire slice. Okay, so you can see the difference, right? Instead of going multiple times around the patient to give you the cut slices, this cone beam, only one single rotation, it is going to give you the entire slices. So that is why CBCT is considered slightly superior when it comes to your dental x-rays alone. Okay, When it comes to your dental x-rays alone, CBCT is preferred over CT. But the difference, the pros and cons, no? If you look at the CT, the bony structures are clearly distinguished. Okay, it will be pucker distinct in case of your CT. So CT is very, very superior in giving you the detailing, the fine details of the bony structures. So for that, CT is very, very useful. It is much more superior to your CBCT. Although CBCT has a reduced X-ray exposure, CT gives you the fine detailing. That is the importance of your CT. CBCT versus CBCT, CT versus CBCT. So whenever you expose the patient to any kind of X-ray, you should look at the risk versus benefit. Then only you project the patient to that particular radiation. Okay. Yep. So this is what I already explained to you. The image acquisition, everything is almost the same as that of the digital X-rays. Okay. So you have the rotating gantry, patient in between, X-ray source on one side, receptor on the other side. It is going to move around the patient, collect the X-ray image, collect the source of the image in the receptor. That is your, I think you remember the flat panel detectors, right? That time itself I told you. When it comes to the sensor, in case of your CT, CBCT and all, mostly it is the flat panel detectors. It is covering a large portion of the body, right? So this flat panel detectors are the receptors here, and they are going to capture the X-rays after passing through the human body, and then they'll be reconstructed by a computer algorithm. So the raw data will be reconstructed to give you the final three-dimensional image. Okay. Yep, I think this is what I was telling you, CT versus CBCT. So fan shape beam, cone shape beam, helical progression, that is the spiraling motion. This one single rotation will give you the entire region, and this one incorporates something called as an FOV, that is the field of view, to get the particular region. Okay. Yep. So this one is not very important for you. Yeah, when it comes to your CBCT, no, patient can be positioned in three different positions. First is the sitting position, same like in case of any physical disabilities and all, no, patient is having that, then you can ask the patient to sit on a chair and then you can expose the patient. And supine position, similar to your CT, standing position like your OPG. Okay, so sitting position, supine position, standing position can be taken in all the three positions. And see, nowadays, if you see, you have your OPG machines integrated with your CBCT X-ray. Okay, so it's just like there will be small modifications in the computer programming and in the system. Okay, so what the configuration will be slightly different, but the same X-ray machine can be used for taking both the OPG, CEF as well as the CBCT X-rays. It's just that there will be some additional programming present in the computer. So after the X-rays are being captured, the adjustments will be made so that it will give you the reconstructed 3D image. Okay. This scan volume is similar to your field of view, like I mentioned, no? See, this one you can see, right? The field of view is 15 to 15 centimeter to cover the entire facial region, but the skull is not covered here. So 15 into 12, it covers till the infraorbital region. Then this is for the entire maxillary and the mandibular arch. This one is limiting it without the TMJ. This one and all covers the TMJ, right? This one is limiting with only to the jaw region. That is only to the dento-osseous region. This one is segmental X-ray, 6 into 6 centimeters. This is nothing but the field of view or the region of interest. So as it is, you all know the applications of your CBCT, right? It is used in case of periodontal assessment, endodontic treatment, dentofacial trauma, implant assessment prior to implant, and then for reconstruction and all that, and also for pre-implanting, like to measure the bone length, the width and all, no? Before implant placement also, it is very, very useful. And for bony pathosis, in case of any three-dimensional analysis also, it is very useful for planning the orthodontic surgeries, TMJ to assess if there's any abnormalities, or in case of any surgical procedures also it is very useful. To look at the developing dentition, airway assessment, 3D cephalometrics, and rapid prototyping is something like your after a mock, like to prepare for a mock surgery, no, giving that three-dimensional planning. For that it is very, very useful. So these are the applications of your CBCT. So last thing is about your MRI. See, for MRI, we are going to make use of a magnetic field. So imagine the patient is being placed within a magnetic field. Okay, the entire machine is there, or the MRI machine will have a strong magnetic field around like 3 to 3.5 Tesla. Tesla is the unit of magnetic field. So these magnets will be placed around the patient, and we know that hydrogen ions are present in our body, right? So these atoms will spin according to the magnetic field. So whenever the strong magnetic field is switched on, no, what will happen is these atoms will, whichever is half hazard in motion, it will try to align with that of the magnetic field. And once when the power is switched off, this will return back to the normal position. So some atoms will return back, some others will be in the same aligned position itself. So when they are trying to return back to the normal position, no, it will produce some kind of energy or a radio frequency. So this radio frequency will be captured by the sensor or the receptor of the MRI machine, and this will convert this signal to the final image. Okay, so this energy or the radio frequency pulse will be captured as a signal by the receptor to convert this signal to the final radiographic image. Okay, so MRI makes use of a strong magnetic field. So your patient is going to be placed within this magnetic field, and the hydrogen atoms will be simply moving here and there within our human body. So once the magnetic field is switched on, this will try to align with that of the external magnetic field. So when the power goes off, some will return back to the normal position, some will stay in that position itself. So this difference is going to create something called as a radio frequency pulse, and this radio frequency pulse will be captured by the receptor, and it will give you the final radiographic image. Okay, this signal will be captured and it will give you the final radiographic image. These are the 5 steps in the functioning of your MRI. Okay, when you look at CT versus MRI, no, CT is very, very useful to look at the osseous structures. Like I told you, it gives you the fine detailing of the osseous structures. And when it comes to the soft tissue structures, your MRI is the most superior, and it is the gold standard, okay, to view the soft tissue structures. There is also a soft tissue window in case of a CT, okay. So if there are like any soft tissue lesions also, it will be useful to view that particular thing. But the gold standard is your MRI only. Okay. So soft tissue means MRI, hard tissue structures means it is CT. Just remember that way. So when it comes to your CT, the difference is soft tissue window and bony window. In case of your MRI, we call it sequencing. Okay, T1 sequence, T2 sequence, flare sequence, and all that. So T1 sequence, basically it helps you to identify the normal structures. T2 sequence helps you to identify the pathology. This flare sequence means it's like fluid attenuated. Yeah, fluid attenuated imaging. Okay, so in that, if you see, what actually happens is in the pathology and all, it will try to suppress the edematous or the inflammatory fluid, so you'll be able to look at the pathology very clearly. It will be delineated very clearly. So these different sequences are indicated for different types of lesions, and it depends on the region of interest also. Okay, so here it is soft tissue window and bony window. Here it is different types of sequencing. Okay. Yes. So last is your nuclear imaging when it comes to your extraoral imaging. So nuclear imaging makes use of radioisotopes. So what actually happens is we try to inject the radioisotopes, and after it is passing through the human body, we try to capture that using a gamma camera. So this gamma camera, what it will do is it will try to capture that radionucleotides. For example, you have cancerous lesions. No, we know that cancer tries to metastasize to different areas, right? For example, if there's cancer in the brain, it can try to metastasize in the liver or in the lungs or elsewhere also. It can spread. Metastasis means distant spread of the lesion. So to look where and all it has spread, what we'll do is we'll inject the radioactive material within the human body. So this cancer cells will trap all those radioactive dye. Okay, and it will start to luminous, it will start to glow up. Okay, so when you capture with the whole body using a gamma camera, this wherever this nucleotide has been taken up by the cells, it will start to glow up on the gamma camera. So it will help you to identify, okay, these are the spots where and all the cancer has spread. Okay, normal cells will not take it up, but the cancerous will try to take it up. So there are different types of dyes for different types of lesions. For example, if you have to look at a bony lesion means we try to inject a dye called as technetium 99M. Similarly, for salivary gland tumors and all, we inject this gallium. Okay, and for endocrine, most importantly, your thyroid. It is very sensitive to iodine, right? So iodine 123 or I-131 is the radioactive isotope that is used. So for different types of cancers, we use different types of dyes. So it will be taken up by that particular cancer cells and it will luminous when captured by a gamma camera. Okay, so this is a nuclear imaging. So now there has been a fusion technique, that is a combined imaging, where we combine two different techniques. Like under your nuclear imaging only comes your PET and your SPECT. Okay, PET is nothing but your positron emission tomography. SPECT is your single positron emission tomography, computer tomography. So this PET is combined with your CT and SPECT is also combined with your CT. The reason being, although this nuclear imaging helps you to detect this metastasis and all that, no, the fine detailing, that is the borders of your osseous structures, the delineation between your pathology and the normal, these things, these fine details will not be very clear in case of your nuclear imaging. So to compensate for that, what they will do is they will do a fusion imaging. They will combine the SPET and the CT. We know that CT gives you this fine nuances, right? That is the fine detailing of the bone structures and all. So when you combine the SPET and the CT, this PET CT is a hybrid image, will give you both the metastatic information and also the it captures the fine details. Okay, similar to that only is your SPECT CT. PET CT, SPECT CT. Okay, these are fusion imaging or combined imaging. Okay, so when it comes to extraoral radiography, I want you to know another important concept, that is your silography. Sal Salivary glands and silography is very, very important to the dentist perspective, right? So we have three important salivary glands, your parotid, submandibular, and the sublingual salivary glands. So these can have numerous pathologies like inflammatory pathologies because of any kind of lith or any ductal inflammation, or there can be cancerous lesions also, or any kind of infections also. So to detect these pathologies of the salivary glands, apart from the routine radiographs, the silography is another important technique. Okay, so for this, taking the silography, there are three phases that are involved. First is the pre-operative phase. Okay, second is the filling phase, third is the emptying phase. The reason why we call it is because we make use of dyes. Okay, so these dyes will be radio opaque. Okay, these dyes will be radio opaque basically. So these dyes will be passed through the ductal tubes. Okay, and it will go and fill up the areas of the pathology. It will be taken up at the areas of pathology, and after that, what will happen? We have to remove that dye also. It should not be retained inside the body. No, it has to be removed. So after filling up, it should come out of the body, so that it whenever the X-ray is taken with the dye inside, we'll be able to identify where the pathology is clearly. Okay, so for that only, the pre-operative phase is like taking a scout radiograph. First, we'll take a radiograph without injecting the dye. That is called as the scout radiograph. Next is the filling phase. Filling phase is when you start injecting the dye through the duct. Okay, for example, the Stenson duct for your parotid, your Wharton's duct for your submandibular gland and all that. So you will try to inject the dye through the duct and it will go and fill up the entire ductal region. And then after filling phase, we'll take another image. So we'll compare these two to look at how the pathology has been happening there. Okay, and last is the emptying phase. So to inject this dye, we have three important techniques. First, the simple injection technique. Second is the hydrostatic. Third is the continuous infusion pressure monitor technique. Simple injection is something like passive, just injecting it using some similar to a syringe. Okay, so you'll just inject the dye and then it will pass through the thing. Hydrostatic is, this is also something like a controlled only, along with some water molecules and all. No, it is something like an external device that uses this water molecules and all, and then will be injecting the dye. Continuous infusion is this is something externally programmed. Okay, continuous infusion will be continuously infusing the dye, and the pressure of the injection is going to be monitored. That is why it is continuous infusion pressure monitor. Okay, so these are the three techniques in which the dye will be injected. The three phases are pre-operative, filling, and the emptying phase. Okay, so this particular dye that we are injecting, no, it is of two bases. Okay, it is either oil based or water based. So each one has its own advantages and disadvantages. So if it is an oil based medium means, what is the advantage? if you see that it is going to be slightly dense, right? So because it is dense, it has a high viscosity. So what will happen is it will be the excretion. If you inject that oil based dye, what will happen? It will slowly infuse through the ductal architecture, and then the excretion of it is going to be slow. So since it is present there for a long time, for you to take the x-ray, look at it and all, you have some time. It's not going to be immediate, so it will travel slowly through the duct. You have time for taking the image and viewing it clearly. Also, since it is slightly denser, it is densely radiopaque, so it gives a good contrast. These are the advantages of an oil based medium. Whenever there is an advantage, there is going to be a disadvantage, right? So the disadvantage is, because it is going to be ejected slowly, what will happen? Sometimes it will be retained within the ductal architecture itself, leading to the formation of something called as granuloma. Okay, so it can cause an allergy and it can result in a foreign body reaction at a later stage if it is not excreted properly. Okay, so high viscosity means, another thing that we have to be cautious is, sometimes it is difficult to give the contrast in case of a calculi and all. No, it will sometimes, what will happen, it will tend to push the calculi down the main duct, so it will go and get blocked elsewhere. It will try to push it very easily. No, so that is why it will go and get blocked elsewhere. So these are the advantages and disadvantages of your oil based medium. In case of aqueous, no, it's just the opposite. It is very very low dense, no, so that is why the contrast is not going to be good. So disadvantage. Second thing is, the excretion is very fast, so to capture the image and all is slightly difficult in case of your aqueous medium. And this low viscosity, so you can it can be easily introduced, so the flow of it through the duct is going to be very easy. That is the first advantage. Second thing is, it can be easily applied and easily removed from the gland, so this is another advantage. Third thing is, it is easily absorbed and excreted if it is in case of the extravasation lesions and all. No, it is very very easy. So these are the pros and cons of using an oil based and an aqueous based dye for contrast dyes for xylography. And these are the names of the dyes. Okay, for ionic aqueous solutions, it is ditrizoate and metrizoate. Okay, for non-ionic aqueous solutions, it is iohexol. Oil based ones include your iodized oils like lipiodol and ethiodol. Okay, so these are the different types of contrast medium that is used for your xylography. Yep. So based on the different xylographic appearance, I think these were asked in MCQ for you. Okay, they might ask you. So in the first table, I have listed out the normal xylographic appearance of the parotid and the submandibular. I want you to remember certain key terms alone. Okay. So yep. So here you can see here, right? The normal xylographic appearance of your parotid gland is the tree in winter appearance. Okay, remember this. Your normal xylographic appearance of your parotid gland is tree in winter appearance. For your normal xylographic appearance of submandibular gland, it is bush in winter appearance. Okay, so parotid, it is tree in winter. Submandibular gland, it is bush in winter appearance. Okay, so this will tend to change in case of pathologies. So I will tell you in the forthcoming slides. So in case of your Sjogren's syndrome and all, now what will happen? The entire duct will get weakened because of escape of the contrast medium out of the duct. So it results in a dot or a blob like structure appearing outside the duct. Okay, in case of sialadenitis, what will be the sialadenitis is nothing but inflammation, right? So inflammation, so that what will happen, the entire contrast medium will be collected within the ductal architecture and it will appear bloated. Okay, so this is how the sinus will be dilated following the collection of the contrast medium. Okay, so in case of Sjogren's syndrome, everything will be ejaculated outside. In case of sialadenitis, everything will be collected within the ductal structure. So these are the xylographic appearances in different pathological conditions. Okay, so in case of the calculi, what will happen? There will be presence of the xylolith somewhere in the ductal tube, right? So beyond that, the fluid will not be there. So there will be blockage of the fluid within the duct wherever there is a xylolith placed. So what will happen? The ductal dilatation will be there beyond that particular calculi. So this is how it will appear. In case of xylodochitis, no, xylodochitis is nothing but inflammation of the ductal orifice. So it will give you something like a segmented sausage link appearance. Okay, so there is going to be dilatation and there's going to be stricture, right? So this dilatation stricture is going to give you a sausage link appearance. Okay, next is sialadenitis. This one only I showed you the previous picture, right? Inflammation of the salivary gland as such. Sjogren's syndrome, I told you this dots or blobs. And intrinsic tumor, no, for example, your adenoma and all that, no, it gives you a ball and hand appearance. This one, I think it was asked in the previous exam or something. Okay, so it is most commonly asked question only. So in case of intrinsic tumors in xylography, it gives you a ball and hand appearance. See, this radiographic appearances as such, no, if at all I have a tabular column, I will try to pass it on to you. Just for normal, like last minute revision, I want you to revise all those things. Like for snow driven appearance for pin box tumor, and this one ball and hand appearance, all these things, no, they can ask in MCQ, so I want you to remember all those key points. Okay, so this is about your xylography. And apart from the diagnostic perspective, your xylography can be used for intervention also. See, whenever there is a xylolith being present, no, what we'll do is we try to insert this catheter through the duct, and this will just get blown up like a balloon, and it will capture the xylolith, and then it can be pulled outside. So it's called as interventional xylography. Apart from being for the diagnostic purpose, it is also useful for the intervention, that is the treatment purpose. Okay, this is interventional xylography. Okay, so apart from 2D and 3D, we have something called as 4D also. This 4D imaging is mainly for capturing the function or the kinetics of any particular region. So this captures the fourth parameter, that is the time, and basically it is used to capture the motion kinetics of the TMJ. And in case of ultrasound and ultrasound 4D, if you see, no, in case of fetal ultrasound, for example, you can be able to capture the movements of the baby, the fetal movements and all can be captured. So that is your 4D imaging. For us, the one is for the kinetics of the TMJ, we can make use of the 4D ultrasound, 4D imaging. Okay. So when it comes to the interpretation, okay, so when it comes to the interpretation, I want to get back to yes. When it comes to interpretation, yes, let's go for this one. So so now that you know how the X-rays are being captured and all that, right? Yeah. So now that the X-rays are being captured, now you got the, you know, the techniques and all, right? So you have to diagnose the image, right? So for that, you have to get familiar with the normal and the abnormalities. So yes, there are certain steps in interpretation. Okay, so first, whenever you have the X-ray in hand, I want you to localize the abnormality. So localizing means you have to identify where it is present, whether it is present periapically or surrounding the tooth, whether it's present in the anterior region, posterior region, maxilla, mandible, or in the entire jaw. So we have to localize where the abnormality is present. That is the first step. Second thing is identifying the position. Okay, so identifying the position means again looking at the epicenter, from where it is coming. We should know, no, it is in the periapical region or the coronal region or involving the entire tooth. So identify the position of the lesion. Third thing is analyzing the shape and the periphery of the lesion. So analyzing the shape, as in some lesions will be well defined, no, it will have a well defined cortex. Some lesions might have a sclerotic margin. Some things will not have irregular margins and all that. So we have to identify the shape and the periphery of the lesion, whether it's unilocular, multilocular, all those things. Next, looking at the internal structure. So when it comes to the internal structure, it can be either radiolucent, radio opaque, or a mixed radiolucent, radio opaque lesion. So we have to analyze the internal structure. And the last one is effect on the surrounding structures. For example, there can be a lesion that can cause resorption of the tooth, resorption of the bone, affect the adjacent tooth, or it is going to involve the base of the mandible and all those things. So we have to look at the effect on the surrounding structures. Okay, so 5 main steps. First, localize the abnormality. Second, identify the position. Third one, analyze the shape and the periphery. Fourth one, analyze the internal structure. Fifth one, effect on the surrounding structures. Okay, so based on this, we are going to do an radiographic analysis. So this is the analytical approach, the first one that I told. Second one is the non-analytical approach, or the Ant Mini method. So mostly we don't go in for the Ant Mini method. The radiographic analysis is going to involve the analytical approach. Okay. Okay, the first step that I told you, right? Localizing the abnormality, whether it's located in the maxilla or the mandible, or it is located in the coronoid, condyle, base of the mandible, anywhere. Okay, and localizing is also going to involve whether the lesion is unilateral or bilateral. In case of a cherubism and all, bilateral lesion will be present. No, so whether it's unilateral or bilateral, whether the lesion is crossing the midline or not. Okay, see, some lesions will tend to spread mesiodistally. Some lesions will spread buccolingually. Okay, for example, your OKC and all will tend to spread mesiodistally. It will be from mesiodistally. Okay, your ameloblastoma and all spreads buccolingually. That's going to be buccolingual expansion of the lesion. Okay, so these are key features which help you to identify or give the diagnosis. Okay, so first thing is you're localizing the abnormality, maxilla, mandible, or the associated structures, unilateral or bilateral, or whether it's crossing the midline or not. And next one is after localized means next thing is generalized, right? So generalized lesion is involving the maxilla, mandible. For example, your this thing, no, your Paget's disease, or in case of your floral cementosseous dysplasia, floral cementosseous dysplasia. For that and all, it is going to involve both the jaws and the entire jaw, right? So they are generalized lesions, or any kind of endocrine abnormalities. So these and all are generalized lesions. Okay. Yeah, these are the examples that I have put for you. Yep. Unilateral, any kind of particular pathology, like you can see right antigerous cyst here, and bilaterally you can see the lesion is present on either side. This can be a case of cherubism also. Okay, so generalized abnormalities. You can see it is an example of a endocrine disease or metabolic disease. Say, for example, Paget's disease maybe. I'm just telling you the differential diagnosis. It doesn't mean this X-ray is an example of Paget's disease. No, I'm just giving you the differential aspect. Okay. So next thing is identifying the position. So identifying the position, whether it is present within the hard tissue or the soft tissue, if the lesion is within the bone, it is well defined or not. Where is the epicenter of the lesion? From where is it starting? Okay, so the difference is, for example, no, certain lesions will be specific to certain regions. Okay, for example, your ameloblastoma or dentigerous cysternal is most commonly present in the posterior aspect of the mandible. Your adenomatoid odontogenic tumor and all is most commonly present in the maxilla, right? It is going to involve your impacted canines. So these things are specific to particular region, right? So identifying the position will help you to narrow the diagnosis. Okay. Yes. So whenever the epicenter means the from where the lesion is originating. Whenever the epicenter is coronal to the tooth, it means it is odontogenic in nature. Okay. And similarly, if it is mostly present periapically, or if it is not touching the tooth, or it's not involving the tooth, it is non-odontogenic in nature. Okay. The reason being, if you have a radiolucency, for example, no, radiolucency that is present in the periapical region, if it is involving the apex of the tooth, and if there is any kind of abnormality in the tooth, no, then we have to correlate it with the odontogenic pathology. Okay, patient is having decay, because of the decay only that radiolucent lesion has happened, so we'll be correlating it with that. If it is just like some solitary radiolucent lesion, it is not connected to the tooth means, then we have to think it as a non-odontogenic lesion. Okay, what could it be? Why is it there? So we have to look at the epicenter of the lesion to correlate whether it is odontogenic or non-odontogenic in nature. Okay, so this can be distinguished with the help of your inferior alveolar canal also. If the lesion is present above the inferior alveolar canal, above the inferior alveolar canal and your teeth is present, no, so it is odontogenic in nature. Below the inferior alveolar canal means it is non-odontogenic in nature. Sometimes it can be seen involving the inferior alveolar canal also, so that time it will be neural or vascular in origin. Okay. Yeah, below the inferior alveolar canal means it is non-odontogenic in origin. If it is present within the neural canal, it can be either neural or vascular in nature. Sometimes the lesion can be restricted within the lining of the maxillary sinus, which means it is limited to the sinus pathology. Sometimes it can be present in the alveolar region. It is not connected with the tooth or so it will be linked to the alveolar pathology. It can be any kind of radiopacities involving the bone, can be osteoma, osteoblastoma, anything like that. Okay. So analyzing the periphery, like I told you, your cysts and all, no, they will have well defined corticated margins. Okay, in case of your cancerous lesions and all, no, the margins will be irregular in shape, so it will show irregular borders, and sometimes it can reflect on the aggressive growth of the lesion, for example your OKC and all that. Okay, sometimes, no, the infected lesions will be less virulent and the surrounding bone will be sclerotic in nature. So it is very important to analyze the periphery and the margins of the lesion to conclude with the diagnosis. So in case of your punched out borders, no, in case of your multiple myeloma and all, no, this can be a distinguishing feature. This corticated border is seen in case of your cystic lesions. Well defined cortex will be seen. Okay, sclerotic margins, again in case of any kind of mixed lesions and all, no, sclerotic margin will be seen. Soft tissue capsule, in case of a radio like a mixed lesion, no, you will have a a radio opaque lesion with the surrounding radiolucency. So soft tissue capsule, like in case of osteoblastoma and all, sometimes a soft tissue capsule will be seen surrounding the lesion. Okay. So in case of your cancerous lesions and all, no, if it is like a non-aggressive lesion, in case of your abscess and all that, no, it can have a blending border, which means it is non-invasive in nature. That is, the margin of the lesion will be blending with the surrounding bone. Okay, so this is called as a blending border, mostly for non-aggressive lesions. In case of an invasive border, where the margin of the lesion is invading into the surrounding bone, it's like encroaching something, it will go and encroach the surrounding bone. So in such cases, no, it is mostly for aggressive lesions. In case of tumors, cancerous tumors and all, no, it will go and eat up all the surrounding bone, so it will have an invasive border. Okay, so these are mostly noticed in case of your malignant lesions. Okay, analyzing the shape of the lesion, whether it's exactly circular or irregular in shape, or see, the circular, one single circle is present means it is unicentric, okay, or unilocular. In case of scalloped lesions, whenever there is a multilocular lesion, what will happen? The outline of the circles, if you see, it will give you a scalloped shape. Example, the best example is your OKC. It will have a scallop margins. Your ameloblastoma can either be unilocular or multilocular, right? So analyzing the shape of the lesion is very, very important. Looking at the internal structure. See, like I already told you, the internal structure can either be radiolucent, radio-opaque, or a mixed radiolucent, radio-opaque lesions. It can either have fat, fluid, bone marrow, bony spicules, your dead bone, that is the sequestrum, can be present, anything of it inside, right? So sometimes, metal particles can be captured inside, leading to foreign body granulomas. So the next step will be analyzing the internal structure of the lesion to categorize it. Okay, so radiolucent, radiopaque, or a mixed radiolucent, radiopaque lesion. Okay, so looking at the radiolucent lesions, sometimes there can be destructive bony lesions, that in case of pathologies like your cancers or carcinomas or your sarcoma and all that, no, they will have a particular geographic pattern of bony lysis. Um, say for example moth-eaten appearance, or in case of your sunburst appearance. So all these things, no, these are destructive bony lesions. So this is how you identify the lesion, depending on the how the pattern of the lysis has happened. Okay, yeah, the three patterns are like giving it a geographic pattern, or something like a moth-eaten appearance, or giving a permeative. Permeative means there'll be rapid areas of rapid destruction, and bone expansion will not be seen. Okay, so this is about the three different patterns of destructive lesions. Okay, so when it comes to analyzing the internal structure, like I told you, in case of multilocular lesions, there are three main important variants, I can say. Okay, so first is the honeycomb appearance, second is the soap bubble appearance, third is like the a tennis racket appearance, and there's one other also, wispy pattern. Okay, so honeycomb appearance means everything will be same, it's all of the same size, there's multiple locules are there, no, it will be all of the same size, honeycomb appearance. Soap bubble appearance will be different shaped, different sizes of the locules that are coalesced together. Coalesced means joined together. Okay, remember honeycomb, all of it will be almost same. You have seen a honeycomb, right? It will be almost all the same size. So it'll have the same size of locules. Soap bubble will have different sizes of the locules. Tennis racket appearance is distinct for your odontogenic myxoma, where the locules will be present at right angles to each. The septae will be present at right angles to each other. Okay, so giving it a tennis racket appearance. And the scalloped pattern is characteristic of your OKC. Yes. See, when it comes to your multilocular lesions, there are different differential diagnosis. So it can be either CG, or it can be your amyloblastoma, many other things. So I think I have mentioned it in the forthcoming slides, the DD and all. So if at all it's not there, I'll try to pass it on to you. Okay. So radio opaque lesions, yeah. So radio opacity can be because of any bony abnormality, stimulation of a new bone formation, or there's going to be residual bone that is left out, resulting in the formation of a lesion, or improper patterns of the trabeculae that is forming into a lesion. So these are the reason why you have radio opaque lesions. Okay. So the ground glass appearance in case of your fibrous dysplasia, your new bone formation, or septations present within the bone, or sometimes sequestrum in case of your osteoradionecrosis and all. No, the presence of sequestrum in case of osteomyelitis also. So these are lesions that give you the radio opaque kind of an appearance. Apart from that, no, your presence of an amorphous bone or presence of odentum, compound or complex. Compound odentum will resemble your tooth. Complex odentum will resemble your, it's like a disorganized tissue. And dystrophic calcifications, example is your pulp stones and all that. Okay, so this is about the internal structures. The next one is the effect on the surrounding structures. Like I already told you, there can be resorption of the root, or it can cause displacement of the teeth, or it can displace the adjacent structures. It can displace the canal itself, your inferior alveolar canal itself. It can be displaced, right? So these are the effects on the surrounding structures. Okay, apart from that, it is important to notice the PDL. Okay, that is your periodontal ligament. There can be localized widening because of any lesion to one particular tooth, that is odontogenic pathology. That particular tooth alone can have a localized PDL widening, or there can be generalized PDL widening in case of any kind of endocrine abnormalities or any kind of other generalized abnormalities. Now, there'll be generalized widening of PDL space. Okay, lamina dura. Lamina dura is not a structure, but I think you're familiar with the peripheral eggshell effect. No, today only I taught you. So because of the peripheral eggshell effect only, this lamina dura is a kind of noticeable feature. So there can be localized loss of lamina dura or a generalized loss of lamina dura. Okay, and apart from that, the periosteal bone reactions. See, periosteum is like the outer surface or covering of the bone. So because of these lesions, there can be an impact on the periosteum of the bone, resulting in the peripheral bone reaction. So these periosteal bone reactions can be of different types, and there are a few standard examples like your onion skin appearance in case of Gary's osteomyelitis, your sunburst appearance in case of sarcomas, osteosarcomas. So these are some distinguishing noticeable features. So this periosteal bone reaction can take place because of four main reasons: because of any kind of trauma, tumors, infection, or drugs, and it is most commonly seen in case of mandible than your maxilla. Okay, and it can either be non-aggressive or aggressive. The non-aggressive types are thin, tall, solid, thick, irregular, and septate. Aggressive can include your laminated, spiculed, sunburst, disorganized, and Codman's triangle. Okay, so these are the morphological classification of your periosteal bone reactions. And the displacement that we were talking about, right, the teeth displacement, similar to that, I already told you the inferior alveolar nerve canal displacement. It can either be displaced, enlarged, or destructed. Okay. So next is the cortical plate. So the effect on the surrounding structure is going to involve your cortical plates also. There can be expansion of the cortical plate, destruction or erosion of the cortical plate. One cortical plate can be intact or eroded. Like for example, no, there can be buccal expansion alone, or there can be lingual expansion or bicortical expansion can be there. Similarly, one cortical plate alone can be eroded, or both the cortical plates will be eroded through and through. It will be lesion will be involved. So there are many variations for it. Okay. Yes, so this is the key thing that I told you. See, the listed below is the differential diagnosis when it comes to periapical radiolucencies. I have made it more easier for you. The reason being, if at all they are giving you picture-based questions, they've given you a lesion with a periapical radiolucency means it can be either one of this only. So you have to think and then answer. So it can either be a periapical abscess or a granuloma or a cyst. So how you'll differentiate between the three? Abscess means the margins will be irregular. There is going to be a definitive odontogenic pathology. There will be a decay involving the pulp, or RCT will be done and a crown would have been broken, or there can be a fracture in the tooth resulting in this abscess or a granuloma or a cyst. So cyst means it will be well defined. The size of the lesion will be larger. So this will be the distinguishing thing. Residual cyst, where it will be present present. Whenever you see an extraction socket or an empty edentulous region, but a single solitary radiolucency is present, there means it can be a residual cyst. So these are the distinguishing differential diagnosis for periapical radiolucencies. For pericoronal, which means surrounding the coronal portion. So this pericoronal radiolucencies can either involve with radio opacity, without radio opacity. So without opacities means it is going to be a normal follicular space surrounding an impacted tooth, no impacted third molars most commonly. It will have a normal follicular space or sometimes slightly enlarged molecule, I mean the follicular space. There can be dentigerous cyst, KCOT, unicystic ameloblastoma, and ameloblastic fibroma. These are present without opacities. With opacities means COC, your pin box tumor, AOT, ameloblastic fibroadenoma, and odontomas. Next is your multilocular radiolucencies. So this is going to involve your ameloblastoma, odontogenic myxoma, aneurysmal bone cyst, central hemangioma, your CGCG, cherubism, hypothyroidism, OKC. See, when it comes to your multilocular radiolucencies, again, look at the picture clearly. Is it given, is there anything mentioned like soap bubble appearance or honeycomb appearance means think of ameloblastoma. Look at the impacted tooth. Look at whether it's present in the posterior mandible or anterior mandible, if it's present bilaterally or unilaterally. See, look at the position and then answer. Like for example, your CG and all, mostly it will be present in the before the first molar. So it will be present slightly in the body of the mandible region. And you know the difference between CG and peripheral giant cell granuloma, I guess. Central means it is going to happen in the bone. Peripheral giant cell granuloma is a histological variant. It happens in the soft tissue. Okay. And odontogenic myxoma, if at all they have mentioned something like tennis racket appearance. So all those things are the keywords that you have to note. Okay. So cherubism means you'll have it will be in a pediatric patient x-ray, it will be present bilaterally or involving the entire jaw. So these are the distinguishing features that you have to notice. Sometimes they will give you in a question based scenario, they will mention multilocular lesion in a pediatric patient or an adult patient, posterior mandible. Look for the keywords. If it is given in the picture, then look for the key points. How the lesion is being present, whether it's involving the tooth, resorption is present or not, because OKC is like an aggressive lesion, right? So most commonly it tends to cause resorption of the adjacent teeth and scalloped margins will be present. So that is how you have to differentiate it and see. Okay. Poorly defined radiolucency. So these are the examples of poorly defined radiolucencies. Osteomyelitis, most common example. Okay. Then generalized rarefactions. Generalized means it will be involving both the maxilla and the mandible, both the right side and the left side. Osteoporosis, hyperthyroidism, sickle cell anemia, thalassemia, and all that. Yeah, moving on to the periapical radio opacity. So it can either be solitary or multiple. If it is solitary means involving one particular tooth or it is present simply alone, okay, without involving the tooth. Then multiple means it will be present on either side and all that. So these are the periapical radio opacity, DD for periapical radio opacities. Diffuse radio opacities in case of any endocrine abnormalities or developmental abnormalities, okay. So these are the examples of diffuse radio opacities. Okay. Yes, the last part of it is your radiographic faults or your artifacts. So basically, a good quality photograph, it should have an optimum density and contrast, and it should have minimum distortion. Okay, and the last one is the borders have to be sharp and the detailing has to be maximum. Okay, so whenever that is missing, we call it as faulty radiographs. The reason why we should know about artifacts of faulty radiographs is there is going to be loss of diagnostic information, and it is going to confuse you with your diagnosis. It can sometimes mimic the pathology, right? So these artifacts, if you see, it is caused because of four main errors: projection errors, processing or exposure errors, technique errors, or automatic processing errors. I'll just brush through it, okay? So improper positioning errors can lead to apical end being cut off, or the overlapping of the teeth can take place. This foreshortening and elongation, no? Yeah, if the x-rays, these are the positioning errors. If the x-ray is not positioned properly, either then the apex can be cut off or the occlusal portion can be cut off. And if it is not positioned properly, again it can be beyond the region of interest, and the tooth that you want to be covered will not be there. Okay. Next thing is, yeah, this is also positioning error only. The coronal portion being cut off. Cone cut. This cone cut can be minimized with the help of using your positioning devices, your paralleling technique, like I told you, no. So unnecessary exposure can be avoided also. Foreshortening. See, foreshortening and elongation are just the opposite. Okay. In case of foreshortening, remember the vertical angulation is increased. Elongation, the vertical angulation is decreased. Okay. Foreshortening means image is short. Your vertical angulation is increased. Okay. In elongation, the image is long and the vertical angulation is reduced. It's just the opposite. Okay. Magnification. Again, this is another positioning error only. And herringbone or tire track effect. This is because of reverse placement of your film. We know that there's a lead foil within the X-ray film packet, right? So when you place the white surface has to place the X-ray exposure side. So if it is placed on the reverse, what will happen is there is going to be impression of the lead foil over the X-ray image. So because you'll still get the image, but there's going to be overlapping of this one over the X-ray image, giving you the herringbone or the tire track appearance. Okay. This phalangioma. Phalangioma happens because of your finger impression that is visible on the X-ray. Okay, the interference of your finger placement. Double exposure. This I think in case of your you didn't know that the X-ray film has already been exposed and then you expose it again. What will happen? It will result in the formation of double exposure. Or because of improper movement, no, you expose the same film again, then it will lead to distorted image. Okay, this double exposure can happen in case of your this thing PSPs also. You remember I told you there has to be plate erasing also prior to exposure. But nowadays automatic plate erasing systems are there, so double exposure will be avoided. Blurring because of the patient movement during exposure. Cervical burnout, this is a different entity as such. The cervical burnout should not be confused with cervical caries. Okay, this is something because of your X-ray exposure. It is not a pathology. So the cervical burnout can be distinguished from cervical caries by looking at the margins. Okay, if at all the margins look like it is irregular, or if the margin of the bone, the radicular bone is there, no, here, sorry, the margin of your tooth is there, no, if the this part is being involved on either side, or if it is looking like radiolucency creeping inside the root of the tooth, then it is mostly root caries or cervical caries. So look at the margins. If it is intact, then it is mostly cervical burnout. If it is not intact, then it is cervical caries. Okay, so this is how we have to distinguish from it. Metal artifacts, because of any kind of appliances or anything, no, metal artifacts can be cast. Okay, film exposed in daylight before before processing it. I mean, before dipping it in the processing solution, if you open the X-ray film in the white light, what will happen? The film be exposed to the daylight, so you cannot use that film after that. Next is dark radiograph and light radiograph. These are also exactly opposite. Okay, the reason why you get dark radiograph is because of overexposure, dipping it into the I mean the developing liquid for a long time, or exposing it to high amount of x-rays, overexposure to the x-ray tube, or increased kvp and ma settings, or inadequate fixation. These are the four main reasons why you get the dark radiograph. Light radiograph is just the opposite: underexposure, underdeveloping, overfixation, decreased kvp and ma. Okay, I think this was asked in MCQ one time for you, a reason for overexposure and this underexposure and all. No, I mean, reason for dark radiograph and dark light radiograph. They'll give you four options. They'll ask you to pick one of it. And fixer spots. This can be because of any kind of contamination in the solution. Okay, so whenever the X-ray film is dropped into the fixer without being dropped into the developer, without immersing it to the developer, if you put it first inside the fixer, means it can tend to give this kind of a flared up image, like it'll just wash off all the silver highlight grains, and it'll not give you an image at all. Okay, so this is a film that is accidentally dropped into the fixer without being processed. Okay, so incompletely immersed film. So the region which is exposed to the solution alone will be developed, and the other part will be remaining to be white in color. Okay, so this is incompletely immersed film. Whenever there is dust particles or contaminants in the solution, it can cast impression on the X-ray film. Usage of expired films, improper washing, warping of the film. Warping of the film is like over time what will happen, the gelatin that is present, no, it tends to create this warping of the film. Okay, improper hanging position. So what will happen, the image of that clip will tend to interfere with the occlusal region or the apical region. Scratches, again this is also like a processing error only. writing, we try to write the name of the patient or the data, right? So this thing sometimes can interfere with the x-ray diagnostic quality. Film fogging can happen because of four main reasons: because of exposure to light, because of improper radiation, that is because of backscatter of the radiation, and contaminated chemicals, or deterioration of the x-ray film itself. These are the four main reasons that can cause film fogging. Okay. Fingernail effect is something similar to a phalangioma only, say like holding the film during your processing, no? This can cast your nail mark over the final x-ray. Improper drying again can give you a improper image. Fingerprint of phalangioma, same. Overlap films, like when you're processing, no, like by mistake, if they're placing two films close to each other, and that if there's overlapping means it will be only partially processed. Okay. Air bubbles also, it's like processing error only. Tree-like marks are called as static electricity, because of like suddenly pulling that X-ray cover and then dipping it into the solution. No, it can cast this tree-like marks over the X-ray. Okay. So these things are almost similar to that for your occlusal and your bite wing radiograph, because the processing technique is almost the same, right? And when it comes to your digital x-rays, no, I want you to remember these eight things. Okay. So first is a noisy image, like it will give you a grainy image because of any kind of error within the system or within the receptor. Okay. Non-uniform image density, which means the image is not clear. Some areas will be very radio opaque, some will be very radiolucent. So there's going to be non-uniform image density. Okay. Distorted image, distorted image can be either because of positioning error only, most commonly, like patient is moving during the X-ray exposure. So double image, like I told you, most common with the PSP, but nowadays because of the automatic erasing system, that is not existent. Damaged image receptors. Your sensor is there. No, sometimes it can be bent or broken. So because of that, there can be a distorted image. Improper use of the image processing. So if the system has some fault, no, the system processing system itself has some fault, means it can cause errors. Okay. And effect of the image scanning resolution. This also is in case of PSP only. The scanning resolution is not set properly, means the image will not be processed, right? So that's going to be an error again. So noisy image, like I told you, because of underexposure or overexposure. Non-uniform image density, because of plate overlap during exposure. Distorted image, double image, your damaged image receptors, your malfunctioning sensors, like I told you, no, so it will not capture and give you properly. So in case of your OPG, you have ghost images because of your you can see, right, the spectacles causing ghost images and your ornaments. And then your lead apron sometimes can cast a radio opaque shadow. Thyroid collar effect. And this one, I told you about the focal trough, right? If it is placed more anterior to the focal trough, what will happen? The anterior teeth will be very blurred out, and the jaw will appear very wide. It will give you a smile-like appearance. If it is placed too posteriorly, the jaw will appear very narrow, and the anterior teeth will be very long and narrow. It will be blurred out again. Okay. So whenever the Frankfurt plane is not horizontal, what will happen? It will give you an unhappy face, a sad face appearance. Your condyles will be pointed outwards, and the chin will be lifted up. It will give you an unhappy appearance. Okay. Whenever the Frankfurt plane is very much low, what will happen? When the patient's chin is placed very low, if the patient is looking very low, it will give you an over smiling arc or an over smiling face appearance, and the condyles will be pointed inwards. That is why the patient's head has to be parallel to the floor, and you have to notice that the focal trough, the teeth are placed within the focal trough region. These two are very important things when you're taking an OPG. Okay. And head tilt towards one side means one condyle will be short and one condyle will be longer. Okay, so whenever the tongue is placed against the palate, it will give you it will cast a shadow over the periapical region of the maxillary teeth. So this is your tongue cast against the palate, if it's not placed against the palate. Okay. Whenever the patient's neck is not straight, your vertebral region is there, no, it will cast a shadow there. Okay. And your hyoid and all, it will cast a shadow in the midline region. Okay. Movement during exposure. So because of that, because your OPG has to go around the patient, right? Whenever the patient is moving during the exposure, the particular region which had some distractions while exposure, it will be blurred out. Okay, it will not be captured properly. So this transition to 2D and 3D also has certain errors. This is mostly not asked for you, but for knowledge basis, I have just kept it. Okay. In case of your CT, there are three main things I want you to remember. Physics based, that is, this is your acquisition for your image acquisition based errors. Patient based, that is your metallic particles or patient motion during the image acquisition. And scanner based is like the system, the processing unit. Okay. So these are the artifacts that can happen in a CT. And mostly it is the same as that in case of your CBCT also. Inherent means it's already there in the X-ray machine itself. Patient related is movement during the exposure and all that. Scanner related is the processing unit related errors. Cone beam related is the errors in the X-ray beam exposure. The X-ray parameters are there, no exposure parameters. If at all there is some problem with that, then it can cause artifacts. Okay. Yeah. So these are the errors that can happen in case of an MRI imaging. Just remember the names. It's mostly not very useful for you. Okay. So when it comes to your ultrasound imaging, so these are the artifacts that can happen because of improper capturing of the sound waves, or it can be because of the sound waves not traveling properly through the particular region of interest. No, so these are the errors in the ultrasound imaging. So I'll stop with the radiology class with this. If at all you have any doubt, please feel free to let us know in the Edental group so that we can answer your queries. So let's be interactive in the group. So any doubts at all, please post there. You can send a screenshot of the question that you have doubts, and we'll discuss that particular topic for you. Okay. Thank you and all the best. Thank you.